Good day everyone, welcome to another session of Flip Classroom. We are from Group A and our topic is supracondylar humerus fracture in children. Supracondylar humerus fracture is one of the commonest traumatic fractures seen in children from a fall on an outstretched hand. It occurs most commonly in children aged between 5 to 7 years old. The incidence in males and females is equal, and the most common type of incidence would be the extension type, which covers up to 95 to 98% of all cases, whereas the flexion type only covers less than 5% of total cases. Next, let's have a quick recap on the anatomy. There are several ossification centers of the elbow, and it is important to know the years at ossification and the years at fusion of all these ossification centers so that a correct interpretation of the X-ray can be made. For example, the capitulum will ossify at the age of 1 year old and it will fuse at the age of 12 years old, whereas the radial head will ossify at the age of 4 years old and fuse at the age of 10 years old. This diagram shows the years of ossification and the years of fusion of all the ossification centers of the elbow. Next, moving on to classification. Supracondylar humerus fracture can be classified by using the Gartland classification system. For type 1, it is for non-displaced fracture, whereas for type 2, it is for an angulated fracture with an intact posterior cortex, whereas for type 3, it is for a completely displaced fracture, and for type 4, is for a complete periosteal disruption with an instability in flexion and extension. Next, moving on to presentations. Those with supracondylar humerus fracture usually presented with pain and also refusal to move the elbow. On physical examination, on inspection, there might be a gross deformity, and the most common deformity noted would be the S deformity of the elbow in a posteriorly displaced fracture. There may also be swelling and also ecchymosis in the antecubital fossa. There would also be a limited active elbow motion. For neurological examination, there may be an anterior interosseous nerve neuropraxia, which is the most common nerve palsy with supracondylar humerus fracture. The patient would be unable to flex the interphalangeal joint of the thumb and the distal interphalangeal joint of the index finger. In short, they wouldn't be able to make the OK sign. Other than this, they can also present with radial nerve neuropraxia. They will be unable to extend their wrist, the metacarpophalangeal joints, and also the interphalangeal joint of the thumb. Next, there would also be median nerve injury, so there would be a loss of sensation over the volar aspect of the index finger. Next, it is also important to perform a vascular examination. This involves assessing the pulse and also assessing the vascular perfusion. Moving on, for imaging, it is appropriate to order an epi and lateral X-ray of the elbow. The common findings that could be found on X-ray include the posterior fat pad sign, or also called as the cell sign. There would be a lucency on the lateral view along the posterior distal humerus and also the olecranon fossa. This is highly suggestive of occult fracture around the elbow. Next, there may also be a displacement of the anterior humeral line. The anterior humeral line should intersect the middle third of the capitulum in children of 5 years old and above, and it should touch the capitulum in children less than 5 years old. However, the capitulum would move posteriorly in extension type of fracture and anteriorly in flexion types of fractures. Last but not least, there may be an alteration of the Bowman angle. The Bowman's angle is created by drawing a line parallel to the longitudinal axis of the humeral shaft and a line along the lateral condylar physis as viewed on the AP view. Normally, this angle is about 70 to 75 degrees and it is best judged compared to the contralateral side. However, if there's a deviation of more than 5 to 10 degrees, this is indicative of a coronal plane deformity.
If there is the suspicion of a fracture, the elbow is gently splinted in 30 degrees of flexion to prevent movement and any possible neurovascular injury during X-ray examination. The treatments are divided into undisplaced fracture, posteriorly minimally angulated fractures, posteriorly displaced fractures, and anteriorly displaced fractures. For undisplaced fractures, the elbow is immobilized at 90 degrees and neutral rotation in a lightweight splint or cast, and the arm is supported by a sling. X-ray should be done within 5 to 7 days later to check that there has been no displacement and the splint is retained for 3 weeks and supervised movement is then allowed. For posteriorly minimally angulated fracture, fracture can be reduced under GA if posterior cortices are in continuity. Firstly, traction in the length of the arm with counter-traction above the elbow should be done. Then correction of any sideways tilt or shift and rotation. Gradual flexion of the elbow to 120 degrees and pronation of the forearm should be done while maintaining traction and exerting finger pressure behind the distal fragment to correct posterior tilt. Then feel the pulse. Check the capillary fill time if the distal circulation is suspected and immediately relax the amount of elbow flexion until it improves. X-rays are taken to confirm the reduction and fractures should be fixed with percutaneous cross K wires if the reduction is unstable. The arm is held in a collar and cuff and circulation should be checked repeatedly during the first 24 hours. Repeat the X-ray 3 to 5 days after to confirm that the fracture has not slipped and splint is retained for 3 weeks if reduction is satisfactory. For posteriorly displaced fractures, the fracture should be reduced under GA as soon as possible, then help with percutaneous cross-K wires in which this obviates the necessity to hold the elbow acutely flexed. Care should be taken not to injure the ulnar and radial nerves, and post-op management is the same as for simple angulated fractures. For anteriorly displaced fractures, the fracture is reduced by pulling on the forearm with the elbow semi-flexed, applying thumb pressure over the front of the distal fragment and then extending the elbow fully. A posterior slab is bandaged on and retained for 3 weeks. Thereafter, the child is allowed to regain flexion gradually. For the complications of supracondylar fracture in children, it can be divided into early and late complications. The early complications are vascular injury and nerve injury. For vascular injury, it can cause brachial artery injury, which is the most dangerous early complication, peripheral ischemia, forearm edema, mounting compartment syndrome, which then may cause muscle and nerve necrosis. Therefore, urgent action is needed when undue pain plus one of the following signs is positive, which are pain on passive finger extension, tense and tender forearm, and absent pulse, blunting sensation, and reduced capillary refill time. For the management of vascular injury, flexed elbow must be extended, all dressings should be removed, and if circulation does not improve, do Doppler or angio study, and then repair vessel, grafting, or forearm fasciotomy should be done. In severe cases, consider operative exploration. For nerve injury, it can cause either radial, median, or ulnar nerve injury. Loss of function is temporary, therefore recovery should be suspected within 3 to 4 months. If nerve is intact before manipulation but compromised after manipulation, you should suspect entrapment in fracture and manage with immediate exploration. Lab complications are malunion, elbow stiffness, and heterotopic ossification. Malunion is the commonest, in which forward or backward angulation may limit flexion or extension. Uncorrected sideways angulation and rotation may cause varus, rarely valgus elbow deformity, and then may cause permanent deformity. Cubitus varus is disfiguring. Cubitus valgus may cause left ulnar nerve palsy. Therefore, malunion causes marked deformity and can be managed with supracondylar osteotomy. For elbow stiffness and heterotopic ossification, passive elbow stretch should be avoided, in which this may cause increased stiffness and heterotopic ossification risk. That's all from our group. Thank you.